Good morning. My name is Joan Kavanaugh. I'm a member of Progressives Against Medical Assisted Suicide. If assisted suicide is legal, some people's lives will be ended without their consent through mistakes and abuse. No safeguards have ever been enacted or even proposed that can prevent this outcome, which can never be undone. These are the words of the late Marilyn Golden, who was the senior policy analyst for the Disability Rights Education and Defense Fund. I'm just going to say a few words about Progressives Against Medical Assisted Suicide, and then I will introduce each of our speakers. Progressives Against Medical Assisted Suicide opposes any legislation or court edict that would make it legal for doctors to prescribe lethal drugs to end their patients' lives. We believe in universal, comprehensive, unrestricted, fully accessible, quality health care for all. We actually agree on many issues with those who favor these laws. Many of us advocate for reproductive rights, disability justice, labor rights, the rights of LGBTQ people, jobs for all, and prison and police reform. And many of us are lifelong peace activists. Several worked to help repeal the death penalty in our state. We see MAS, medical assisted suicide, as a frightening and serious step backwards, a threat to the lives of the most vulnerable among us. So we appeal to those who stand for all principles of equality and economic and social justice to also stand with equal strength against this practice. In this society, a person's financial status, insurance coverage, current health status, including disability, gender, age, and race, largely determine the help they are able to receive, including medical treatment of all kinds. It is cheaper to send a patient off to die than it is to meet their needs to live. Why is this reality of our broken and discriminatory medical system conveniently ignored when physician-assisted suicide is being promoted? There are many talented, well-meaning, hardworking, self-sacrificing, and kind people in the healthcare professions, but the larger medical system is driven by profit. We know that death is cost-effective. We know it's cheaper for insurance companies to pay for lethal drugs than it is to treat an illness. In addition, there is tremendous prejudice in our society against the elderly, the disabled, the poor, and black and brown people. Unfortunately, these attitudes have been absorbed by many healthcare providers. Many of us have experienced fear and frustration and pain when the medical system decides that one of our loved ones is costing too much. And we have often heard medical people make judgments about the quality of life or lack thereof of a person they barely know or don't know at all, suggesting that they would be better off dead. I had to battle the twin evils of economic discrimination and social prejudice to get treatment for my own mother, a Medicare Medicaid patient, as she went through the medical system in her last decade of life. We hear these attitudes in the oft-repeated phrase, death with dignity, a mantra for the organizations which push for medical-assisted suicide, as if living with a need for ongoing care or assistance is somehow inherently undignified, as if the care required by many who are disabled, elderly, or seriously ill somehow demeans them and merely burdens caregivers and society. And this attitude is too often absorbed by the patient and the caregiver, as well as by medical practitioners and hospital administrators. A 2020 study by Lisa Iazzoni, professor of medicine at Harvard Medical School, showed that 82.4% of physicians surveyed believe that people with significant disabilities have a lower quality of life than the non-disabled. These prejudicial attitudes and economic barriers go hand in hand to form a major reason why assisted suicide laws are so dangerous. The coercion to make a decision to end one's life may be implicit or explicit or both. Either way, no safeguards written down on paper can ever prevent it. SB 1076 does not change this one iota. Our speakers to follow will be discussing some of the reasons we must all work to defeat this legislation on the basis of social justice and humanity. We appeal to the members of the Public Health Committee and to the entire state legislature, if necessary, to vote against SB 1076. Now I would like to introduce Kathy Ludlam, a leader in Second Thoughts Connecticut. We're very pleased to be co-sponsoring this press conference with Second Thoughts Connecticut. Kathy and Second Thoughts have been struggling against the legalization of medical-assisted suicide for decades. For over 30 years, Kathy has worked as a professional writer, speaker, and facilitator with a focus on defending the lives and protecting the rights of disabled people. Kathy has written many articles and several books, including a manual on hiring personal assistants and One Candle Power, 7 principles that enhance the lives of people with disabilities and their communities. Kathy.
Push the button right there. Can you hear me? Awesome, thank you. Well, thank you, Joan, and thank you to Progressives Against Medical Assisted Suicide for inviting Second Connecticut to participate in this important event today. As Joan mentioned, the disability community has been fighting assisted suicide for decades. It is clear to those of us who already have to fight for medical care that offering a lethal prescription as a treatment option will have far-reaching consequences. Second Thoughts Connecticut is a grassroots disability rights organization that turns out year after year to oppose assisted suicide. We are motivated by a strong sense of social justice combined with personal experience of what it means to be devalued by the medical system. Many of us have survived medical crisis in spite of being written off as close to death or assumed to have a poor quality of life. We have also seen this happen to people we care about. Although the drafters of assisted suicide legislation are proud of their safeguards, as Joan mentioned, no safeguard can prevent the receiving of the wrong diagnosis or a wrong estimate of life expectancy or not getting needed treatments. Just a little case in point. I struggled with life-threatening breathing problems for years. The source was not correctly identified, and I was given inhalers and pills, some of which made me sick and none of which helped much. When I changed doctors and started using a BiPAP to help me breathe better while I was sleeping, I got better. But for a while, it did look as though I might be coming to the end of my journey. I am so glad that assisted suicide was not in the mind of my practitioner. The supposed safeguards in SB 1076 can do nothing to prevent people from dying for the wrong reasons. Tightening the residency requirement seems like an odd thing to do at this time when Oregon has just repealed their residency requirements, and there is right now a lawsuit in Vermont to do the same thing. Proponent Compassionate Choices claims that any residency requirement is a violation of the United States Constitution. So it doesn't make sense how that could work when they say they are going to repeal these all over the country. Second, adding a list of felonies at the end of this new bill may appear at first to be an improvement, but misconduct would be hard to prove as long as the practitioners are acting in good faith. Much of the discrimination people with disabilities and critically ill patients experience is covert. Third, although the bill no longer requires falsification of the death certificate, neither does it require the certifier to list the actual cause of death, the lethal prescription, and the manner of death, suicide. Sadly, as proponents work hard to make it easier for people to take their own lives, other opportunities are inevitably pushed to the side. If hospice and palliative care services are not everything that they could be, fixing that needs to be a priority. SB 1075, an act concerning hospice and palliative care, would be an important step toward giving patients the support they need and deserve. It will also be up for a public hearing today, but unfortunately, it's likely to be eclipsed by the assisted suicide legislation before us, SB 1076. So we urge legislators to vote no on this bad bill. Assisted suicide is bad policy, bad medicine, and bad for people. Thank you very much.
Thank you, Kathy. I'd like to now introduce Nancy Allisberg, a retired civil rights and disability rights lawyer who served for almost 20 years as the managing attorney and legal director of the former Office of Protection and Advocacy for Persons with Disabilities and its successor, Disability Rights Connecticut.
Thank you, Joan, and good morning. I want to tell you some stories about people who would be dead today because their lives as people with disabilities were devalued. I represented a 15-year-old with intellectual disabilities who was diagnosed with a treatable form of leukemia. The hospital ethics committee said he should not be treated because he would not be able to understand why he was suffering from the side effects of the chemotherapy, and because the radiation might cause him to lose additional cognitive function. They decided that his life would therefore no longer be worth living. After OPA's intervention, the young man was treated, he went into remission, and was adopted into a loving family. I represented a 30-year-old woman who experienced a massive stroke after a successful heart transplant. She lost her ability to speak, but not her ability to write. Nevertheless, her family decided that she would not want to live like that, and ordered that the doctors no longer provide her with the anti-rejection medication and no longer provide her with screenings to determine how her heart was functioning. When I met with her, she wrote to me clearly that she wanted to live, and she wanted all treatment to maintain her new heart. The facility where she was living listened to the family and refused to provide that treatment. The family and institutional pressure to kill her, despite knowing her wishes, was profound. I had to go to probate court to get an order requiring her family to consent to treatment. Finally, I also represented a woman with an intellectual disability who had a history of aspiration pneumonias. After her most recent illness, her guardian, who was her brother, decided she'd be better off dead. So he issued a do not resuscitate, do not feed, and do not hydrate order. The hospital was following his orders, and when I got involved, she had not had liquids or nutrition for almost 24 hours. She was not terminally ill, but was made so by her family and the medical providers. I had to go to probate court again to get an order for her to receive hydration and nourishment and to remove the DNR. She returned to her group home and lived there happily for many more years. I used to believe that so-called death with dignity was a valuable right, but I had second thoughts when I realized that all these people would be dead if I had not represented their rights not to be killed. As a lawyer, I know there is no protection sufficient to make people feel that they will not be a burden on their families if they refuse a physician-assisted suicide. There is no protection sufficient for people to resist those who say, "You don't want to live in a wheelchair for the rest of your life," or "You don't want to have to be fed through a tube for the rest of your life." Raise Bill 1076 does not provide those protections and must be defeated. Thank you.
Thank you so much, Nancy. Our next speaker is going to be coming to us through Zoom, and we want to thank Debbie Elkin, our member of Progressives Against Medical Assisted Suicide, for working so hard to set that up. It's been important to do this. Our next speaker, Dr. Diane Meyer, is immediate past CEO of the Center to Advance Palliative Care, a national organization devoting to increasing access to quality palliative care for people living with a serious illness and their families in the United States. She is currently the co-director of the Patty and J. Baker National Palliative Care Center. Dr. Meyer has over 200 peer-reviewed publications in the medical literature. Her most recent book, Meeting the Needs of Older Adults with Serious Illness, Challenges and Opportunities in the Age of Health Reform, was published in 2014. We thank her very much for coming for zooming in from New York City to be with us today, and we look forward to listening to her words.
Thank you so much, Joan. Can you guys hear me?
Yes. Yes.
Yeah, okay. So my name is Diane Meyer. I'm a doctor and I specialize in geriatrics and palliative medicine. I have cared for thousands of people living with serious illness and their families. In this testimony, I will argue that public policy legalizing access to medical aid in dying is unwise. 3 considerations lead me to this conclusion. The safeguards are unrealistic and demonstrably ineffective. Second, physicians are poor gatekeepers. We are subject to numerous external pressures from society, from families, from health systems, and we are not able to protect the most vulnerable from decisions made by other people about the worthiness or unworthiness of their lives. And third, and should be obvious, public policy must not be based solely on majority opinion from surveys, but also on assuring protection from harms, especially for those of us who are most vulnerable. So on the first point, the safeguards. First one is prognostication. Supposedly people are meant to be within 6 months of death. There is abundant literature showing that our prognostic assessments are notoriously wrong. And the great majority of deaths today, 80%, are due to chronic illnesses where death cannot be reliably predicted. Second, determining whether a patient is of sound mind is not simple and requires training, which most physicians have never had, and sufficient time, which no physician has. What sounds like a rational decision is often a cover for complex depression, hopelessness, rage, and fear, which are all hard to talk about and time-intensive. Shortcuts are inevitable, given the lack of training and lack of time characterizing the modern practice of medicine. The third safeguard, identification and treatment of depression. Physicians miss the diagnosis of depression in the great majority of patients and are unaware that depression is a treatable disorder. Despite the requirement that physicians refer for psychiatric evaluation if they suspect such depression, such referral rarely takes place. Once the right to get help with the timing of one's death is established, it then rapidly becomes unfair and inequitable to restrict access to the very people who were meant not to be eligible in the original set of safeguards. Thus, perhaps because of this, there is a lot of evidence of what I will call eligibility creep. As communities of doctors become more accustomed to helping people to die, the practice becomes normalized and routinized. Reports from Holland, Belgium, and now Canada on growing willingness to help people who are not dying, including the demented, the disabled, the mentally ill, infants, and children, to die suggests the real possibility of a slippery slope, provision of medical aid in dying, based again on the judgment by other people that some lives are not worth living. Legalization of medical aid in dying explicitly endorses the state's belief that some of their citizens' lives are not worth living. We do not have to look too far back in history to recognize the risk that this carries. I want to talk about the reality of family coercion. Pressure from families and overwhelmed healthcare systems is a reality. Those of you who have not yet experienced are likely to do so at some point in your life. Given the burdens of care imposed on families when a loved one is seriously ill, access to a legal option to avoid a long period of disability and need for costly personal care has undeniable appeal, but not necessarily to the patient. In one instance, I was contacted by email by the wife of a patient with recurrent brain cancer to discuss his care options. Because of his mobility difficulties, I visited them at their home. It quickly became clear that the purpose of the visit was to see if I would help hasten his death. When I began to explore what had precipitated this request and asked the patient what he feared about the future, he looked towards his wife and did not answer. His wife did. I explained the benefits of palliative care in terms of symptom relief and support for both the patient and the family through the remainder of his life. The patient was interested and asked a few questions about what home care options were available and about what the process of dying was actually going to be like. I described it. He seemed reassured. His wife, however, appeared more and more irritated, saying, "We know all about hospice and we're not interested." When I asked to speak with him individually, she thanked me for coming and escorted me to the door. Had aid in dying been legal in New York at the time, I have no doubt that she would have found a willing prescriber and helped her husband, who had months to live, if not years, to hasten his death. When family members are stressed and burdened by the role, when the illness is bankrupting the family, the patient gets the message. And finally, the role of public policy. A public policy, by definition, has to protect the public from harm. Safeguards do not work. Multiple examples confirm that poverty, housing insecurity, need for paid personal care, mental illness, and overwhelming family stress are often the primary motivator behind the request. In other cases, patients did not even initiate the request, but have been offered aid in dying by clinicians as an alternative when needed support services were not going to be paid for. My submitted testimony includes numerous published examples of these abuses. In closing, I can imagine that I might like to have the option of medical aid in dying at some point in my future. However, my personal preference does not outweigh the very real risks of public policy normalizing state-sanctioned medically assisted suicide. Such change in policy puts tens of thousands of my fellow citizens, particularly the poor, the disabled, the chronically ill, the highest need and highest cost people, at risk of being encouraged to die because our society will not pay for what people need in order to live. In one description published a long time ago, a man with advanced emphysema asked his physician, "Can't you do something to just bring it to an end? Just put me out of my misery. It would save everyone a lot of trouble." His doctor replied, "Even though you feel like a burden, I can't do that." The patient says, "Why not? You do it for your dog." The doctor answers, "Because you aren't a dog. You're my patient, and I'm your doctor, and I'm trying to help you." and I'll keep trying to help you as long as I can." The patient took the doctor's hand in both of his and said, "Thank God. I thought everyone had given up on me." Thank you very much for the opportunity to testify.
Thank you, Diane, so much. Elaine Kolb is our next speaker. She has been a cultural worker for over 50 years. As a poet, songwriter, activist, and performer, her issues range from peace with justice to disability rights to LGBTQIA rights. Elaine joined Americans Disabled for Accessible Transportation, ADAPT, in 1987, and was involved in the passage of the Americans with Disabilities Act, ADA, in 1990. She is a member of Not Dead Yet, as well as Second Thoughts Connecticut and Progressives Against Medical Assisted Suicide. She has been arrested 27 times so far for civil disobedience, mostly with ADAPT and Not Dead Yet, and also with the Poor People's Campaign. Elaine.
Okay, are we on? Are we on? Yes. There, okay. Not a slippery slope. Euthanasia, eugenics is a juggernaut. Some of us have been resisting, trying to hold back this juggernaut for decades. I'm one of them. In a minute, I'm going to sing Not Dead Yet, because we're not dead yet. And yet, there will be people testifying today that they would rather be dead than to be like me, and to be like some of the people that I have loved and respected as family and friends and partners. Life is full of struggles. And birthing and dying have a lot of messiness around them, and yet both are miracles. I have been honored to be present at the moment of death 4 times now. And some of the most precious moments that we share with people that we love are some of those last moments, those last days, those last weeks. I was in one of these rooms at one of these events. Where you can look it up. It's a recording of Not Dead Yet. I was younger then. I was 64. I'm 73 now. I've been here almost every year. But back then, my sister Norma had just had complications after a surgery. And while I was here talking and singing Not Dead Yet, we didn't know if she was going to live. She had a stroke. She wasn't able to speak clearly. And she was in another state, several hours away. I managed to get there. And other family members, they were of the, oh, well, the doctors say we could do a surgery. Maybe that'll help her. And they weren't sure that Norma was with it mentally. I have had, because of my experience and what I've done for most of my life now, had enough experience with people with all different kinds of disabilities, all different kinds of stages. And so when I went to visit Norma, she had had a stroke. Part of her face was sunken. Her left arm and left leg were swollen. And they were wondering, does she know who she is? Does she know what she wants? How can she communicate? I could see the light in her eyes. Palliative care people, people that provide this kind of care, hospice people, people that have had family experiences, we can tell when there's light and consciousness that sometimes comes and goes. So there was Norma trying to speak. I said, Norma, relax. I see you're in there. I'm going to help. I'm going to help make sure that your words are taken seriously. And what she wanted to do was to be able to go on hospice, palliative care, because she was in tremendous pain. And she wanted that so she could recover enough so that she could have at least some moments of sharing. And I was blessed to be able to assist her and the whole family to understand that this is how it was. And once Norma was given the pain medication so that she could be herself, her funny, spunky self. Now remember, she could barely speak. It was very difficult to understand her, and yet she was there and she was speaking, and she was Norma. And one of the most amazing things I've ever seen in a situation like this, there's my sister Norma. She's dying. She knows she's dying. Everybody knows she's dying. And yet, her spirit was still there. And her spunkiness was still there. And there was a really cute male nurse that came in. And Norma, she only had one hand that she could use. She reached out and pinched his butt. She did! Some people would not allow that kind of precious moment to happen. They want to rush things, get it over with. I would rather be dead than to have to wear Depends. Some of them will say that today. I've been listening to it now year after year after year. And yet, when this organization, Not Dead Yet, was first founded in 1996, by the way, that was a while ago, 1996, I wrote a couple of these verses, and then in 2013, I wrote a couple more verses. And this song really, I believe, captures the essence of who we are as people with disabilities who live with dignity and pride, and the people who care about us and love us and honor us. And we're not dead yet. We are not dead yet. And we can boogie with the best of them. We are not dead yet. And we can laugh and have some fun, 'cause we're not dead yet. We're fighting for our freedom and we'll never die, 'cause our spirit will live on. Well, the outcasts of the outcasts become the leaders of today. The ones we used to throw away to die are teaching us a better way. Well, I'm positive if you're HIV, you can understand the song. The last will be first and the first will be last, and there's more than one way to be strong. 'Cause we're not dead yet, and we can boogie with the best of them. We are not dead yet, and we can laugh and have some fun. Oh, we're not dead yet. We're fighting for our freedom and we'll never die, 'cause our spirit will live on. Well, when you take away our services, we don't know how we'll survive. Since death is cost effective, do you want us dead or alive? I think I know what some folks want. Well, we're not dead yet. Woo! When you take away the things we need, we don't know how we will cope. When you set our means of security, you take away our hope. But we're not dead yet. We can boogie with the best of them. We are not dead yet. We can laugh and have some fun, 'cause we're not dead yet. We're fighting for our freedom and we'll never die, 'cause our spirit will live on. You know, we need to expand Medicaid, right? We're going to expand Husky this year. Are we going to really make it possible for people to live in freedom with dignity and pride? I think that's a good idea. What do you think, kids? Well, if Medicaid does not aid us, if Medicare does not care, millions of us will suffer. How can you believe that's fair? If you want to cut back funding, stop the welfare for the rich. Billions bail out the billionaires. We're trapped down in a ditch. But we're not dead yet, and we can boogie with the best of them. We are not dead yet. We can laugh and have some fun, 'cause we're not dead yet. We're fighting for our freedom and we'll never die, 'cause our spirit will live on. Well, it's a battle cry for freedom through the healing power of love. It's the hope we share from our visions deep inside, up above. It's the peace that comes from the struggle to be as brave as we can be. We are proud, we are humble, and the truth will set us free, 'cause we're not dead yet. We can boogie with the best of them. We are not dead yet. We can laugh and have some fun. Oh, we're not dead yet. We're fighting for our freedom and we'll never die, 'cause our spirit will live on. 'Cause we're not dead yet. Yeah. Woo-hoo.
Thank you so much, Elaine. And with that spirit, we're all going to, from Progressives Against Medical Assisted Suicide and Second Thoughts Connecticut, we are going to be carrying forward our message to the state legislators today in the public hearing for the SB 1076. I believe it's, somebody said it's right next door in 1D. And we're going to be testifying throughout the day and really appealing to the humanity and sense of social justice that we know these legislators have to defeat this devastating bill, which is going to create more deadly discrimination in our medical system if it is passed. If there are any questions from the press, we can take them now. Okay. Thank you so much.
Make sure you go up and see the posters.
We have questions.
Stan Heller, TSVN. You mentioned Canada and the system that they have there. How is that working out?
A lot of us could speak to that, Stan. It's a nightmare. It's an absolute nightmare. I think over 10,000 people have died in Canada since the law was passed. And it's coming out more and more in the press in the United States now just how bad it is. People are being denied social services. They're being denied home health care. People are opting for euthanasia, active euthanasia, because they're not getting the services they need. And they are completely eligible for it. It's much cheaper to off people than it is to give them the social services they need. And that's what's happening in Canada. That's the short version. I don't know if Elaine, you want to say anything more about that?
See, this is the thing. Once euthanasia is listed officially, legally, as a medical service, well, you can't deny it to anyone. You know, and when I said it's a juggernaut, it is a juggernaut. And this is what they really want. Don't believe compassion and choices. Do you know their background? They started off officially as the Euthanasia Society. It's true, look it up. And then for a while they were the Hemlock Society. Well, poison, anybody? And then they had a public relations coup. Oh, how could anybody be against compassion? We all love choices. Don't you want a choice? And yet, amongst themselves, if you take the time, and believe me, it turns my stomach, but I do it. I read their stuff. And they talk about it openly. Pass anything. Pass anything. As long as it gets legalized, then you expand it. Then you expand it. Then they always expand it. They've done it everywhere it's been passed in the world, and that's what they want. And if you want what they've got in Canada now, which is, by the way, can you imagine if a hospice program will not kill people, they're taking their funding away. It's a true fact. Look it up. It's happening. And who gets dead? Guess who? Guess who? Low-income people, especially people from other minority groups, especially people that have multiple disadvantages. And they're just killing us by the thousands. And that's what will happen if this juggernaut gains traction in Connecticut. Let's stop it here.
My name is Stephen, S-T-E-P-H-E-N.
Recording stopped.